Hey guys, I am going live today because I want to talk about endometriosis with one of my friends and mentors, Dr. Jessica Drummond. She is the author of Outsmart Endometriosis, and this is going to be an amazing conversation. I see her here, so I'm just going to add her real quick. And hi everyone, so nice to see you all. Hold on a sec. I'm now living in the countryside, so we'll see if my internet works. Oh, hi. Okay, I'm a little bit high up. Hi, can you hear me okay?
Hi,
Hi,
I
how are
can.
you?
How are you? I'm
I'm,
good.
I'm good too. I'm just, trying to like make sure that my internet works because, country. I'm in the country now.
So true. Well, mine,
Yes,
mine, I've actually hardwired my computer in because we have
smart.
everyone schooling from home, working from home, all of
Yes,
that. So,
that's so
yeah,
true. That's actually a really good idea. I think I might do that too because I feel
yeah.
like you never know, especially with
Right.
all
I'm
of
on
these
my
big things
phone
we're
right
doing.
now, so we'll
Yeah,
cross our finger.
yeah, we'll hope for the best. I know.
Yeah.
Anyways, I'm so happy to have you here, Jess, because I have just done a series on endometriosis, and I, as you saw, have tons and tons of questions. And I feel like there's still such an unbelievable amount of miscommunication when it comes to this disease. And I could think of nobody better to come and help debunk some myths because there's a lot. I mean, even the comments, people were like, well, retrograde menstruation. I was like, hold on a second. We need to talk about all of this stuff. So, there's a lot. I think one of the first things is, and I think it's obviously a bit of an obvious question, but is what is endometriosis? Because there is so much misinformation about what exactly this thing is. So I would love for you to describe what endo is as a starting point.
Absolutely. So, what endometriosis is a disease process that is at least partially genetic. So, you sort of have it at birth. There have been studies done in female fetuses. About 9% of those have endometriosis lesions. 10% of adult people with uteruses have endometriosis lesions. So you're sort of born with it, but the lesions can be sort of activated, progressed, they can get worse over time. Usually the symptoms begin in just before like pre-puberty and puberty,
Right.
when the lesions can sort of swell, become inflamed with each menstrual cycle. And of course, it seems irregular at first because it can take up to 12 years for the menstrual cycle to mature.
Yeah.
So the pain and symptoms can be random, but they are influenced by the menstrual cycle. And what those tissue growths are, there are several different kinds of them, but to keep it simple, the tissue inside the lining of the uterus, is called the endometrium. And while it's not exactly the same, which makes it confusing,
Yeah.
the tissue that are the lesions, the tissue that makes up these lesions, is similar to the tissue that lines the inside of the uterus. But how those kind of lesions get lied down outside of the uterus, we know is not related to retrograde menstruation. That has been disproven. But how they exactly get there embryologically and how they proliferate is still rather mysterious from a research standpoint.
Right.
And as I said, there are different kinds of lesions, and then there are other sort of, I think of it as a disease that has three causes: the underlying genetic cause, inflammatory cause, and potentially autoimmune, although that is less agreed upon in the literature. And so it's kind of like cancer. You literally have these growths outside of we're outside of the uterus. So by definition, they are outside of the uterus. Now, it's also a systemic disease. It's not just a reproductive disease. While oftentimes the lesions are on the outside of the ovaries and right outside the uterus and kind of between the uterus and the rectum, they can be all over the bowel and small intestine, which we see all the time with the digestive symptoms associated. They can be kind of on ligaments that are in that general region of the pelvis. They can be on soft tissues, other organs. They can be on, these lesions can be on the bladder, the diaphragm, but they can also be far afield of that. These lesions have been found inside the nose, on the knee, in the lung, have actually caused collapsed lung in the past. So it's a systemic disease that has been, I think, a little bit mislabeled as sort of a reproductive disease. You know, it certainly does impact reproductive health, though, in that it's one of the most common causes of subfertility, because of a lot of different things, from inflammation to just structural getting in the way of things.
Right.
So, because they can, you know, it can be on the fallopian tubes, ovaries. So that's sort of the root causes, the systemic nature of the disease, but there definitely still are questions about all of the etiology.
Yeah, I know, right? I feel like there's still so many mysteries, but that was really, really helpful. And I think that that was one of the questions I was going to ask about, was, you know, the causes. And I know you mentioned a few of those, or at least the three that, you know, that are most discussed. Is there anything more around causes that people should know about? Because I feel like when it comes to removal of endometriosis, in terms of, you know, having a surgery, which we'll talk about in a second, you know, oftentimes women say to me, well, I've had multiple surgeries, it keeps coming back. So can we speak about that for a second? Because I feel like the general understanding is that it's something that you just remove and then it's one and done and we're done. But that's obviously not the case.
Well, and it depends a lot on the kind of surgery you have and who does your surgery.
Right.
Because I've been doing this work for 21 years. And when I used, like, in kind of the first decade of my career, it was very common for me to see women 16 surgeries, 10 surgeries, very common. And we would sort of run out of tools. Like, it was like ablation surgery, which is literally like the burning off of the top of the lesion. So let's say the lesion is sitting on top of your bowel or your bladder or outside the ovary. They would just burn it off. Okay. Right. And then there were, you know, not a lot of tools. So the thought was just opioids for pain, you know, so the management was not very good. That has evolved a lot in the last decade. And so now with endometriosis, skilled excision surgery, which is more like cancer surgery, they cut the lesion out from the root. So, you know, it's a much more complicated surgery. It's still laparoscopic. And usually people who do the surgery do it in concert with general surgeons to address the bowel involvement and the intestinal involvement. But you know, the surgeries have evolved. Now, the challenge is that I obviously have a specialty practice in endometriosis. So the surgeons that I work with, my patients tend to work with, tend to also have specialty practices in pelvic pain, endometriosis. They have a lot of extra training in this kind of microscopic surgery, microscopic laparoscopic surgery. And, you know, I'm not a surgeon, so I'm not an expert on the surgery itself, but actually my colleague, Dr. Iris Orbuck, and another colleague of mine, Amy Stein, wrote a good book called Beating Endo, which does have more about the surgical perspective. Yes. But so that's the thing. There are different kinds of surgeries, and if you think about it, you know, all gynecologists are surgeons. That's how they're trained. So all gynecologists theoretically can do this surgery, but to be done well, it's much, much better. And I see this time and time again in my practice, for it to be done by a person who essentially specializes in this. You know, they're not sort of like some days delivering babies, some days doing these, you know, complex surgeries. This is what they've devoted their time to. Now, maybe not in only endometriosis. They might also do other kinds of pelvic pain surgeries, but they're very practiced with specific, you know, these specific surgical techniques, and not just the techniques, but what they're looking for and where they're looking. You know, if your gynecologist kind of goes in laparoscopically and just looks around. It doesn't really see anything, but these lesions are small and, you know, can be hidden. And so you need someone who knows what they're looking for. Most importantly, because unfortunately, while imaging can be helpful and lab work can be helpful, the only true way to diagnose endometriosis is through a laparoscopic surgery. And ideally, you go in, you know, having done a really complete history and all of the other work that the surgeon does to kind of be quite sure that it's likely you have endometriosis. It certainly does happen where people get in there and they don't find endometriosis, but
I have questions about that. Yeah.
I mean, that happens, but, you know, surgeons who specialize in this do try to, you know, have a pretty high index of suspicion before they do the surgery.
Right.
And then, you know, but again, you want someone who's skilled at finding it. And so, you know, it's complicated because we don't have just a simple blood test or anything like that.
Yeah, that was what I wanted to go into, was about diagnosis. And so just for recapping for everybody, so diagnosis is done by laparoscopic surgery. And what about, like you mentioned, imaging and things like that, and genetic testing and all of those fun things? What about using those as part of the diagnostic criteria? Is that generally done? And like, if so, what? Because that was a big question. Like, what is it that the doctors are doing to, you know, be fairly certain that someone has endometriosis before actually doing surgery to fully diagnose it?
Well, a really good history is actually very important. So a surgeon who listens, because in many cases you're going to hear some kind of family history, which is a little tricky because again, this has a genetic underpinning, right? So it's a little tricky because a lot of times that's part of what keeps it silent. So imagine if, you know, our grandmothers, our mothers, you know, I'm in my 40s, they didn't talk about our periods very much. Probably wouldn't have been like family legend to talk about their infertility. Or if they did, they would say like, oh, most of the women in this family have bad periods. Like, welcome to the club. It's a curse, you know, like it was, and then that's it. Right. So, and it's not, they didn't know a generation or two ago that you could do much about that. It was just sort of seen as like part of being a woman. Right. So that's changing. I have many more sort of teenagers, girls in college who their mothers are and were aware of more of the family history around endometriosis. It's also commonly co-presents with autoimmune disease. So if there's a family history of bad periods, infertility, whether or not endo was diagnosed, because a lot of times they were never diagnosed, but also Hashimoto's and celiac disease are other two common comorbidities. Other autoimmune diseases, that's again a higher index of suspicion. Also, it's the number one cause of girls. Now, of course, we're in a different school environment right now, but assuming regular school, it's the number one cause of girls missing school in middle school and high school. So
the pain, right? The period,
right,
like
and
period
the underlying,
just,
the painful. Not always periods, because in high school it's not always a cyclical pain, or middle school, but digestive pain, pelvic pain, abdominal pain that's so severe that they miss school, miss sports practices, can't show up for the SATs, like things like that. Then again, high index suspicion, or trying to push through, because I mean, it's hard to miss things every month, and like finding yourself in a bathroom on the floor in your school, or in a, you know, vasovagal symptoms, feeling hot, things like that. Anxiety often goes with it, fatigue. So I think that, you know, if a history is really important, including that family history. And then, yes, I'm not an expert on all the imaging and blood work that the surgeons do to sort of pre-assess, but absolutely, there are, you know, ultrasounds and you
Like
can certainly
MRI,
look
CAT
at,
scan. I feel like
yeah,
everyone has
and
said everything to me at this point.
all of them
Yeah.
can occur depending on the circumstance. And again, it can be complicated by other things like digestive issues, Ehlers-Danlos, so the imaging might be looking for other things as well. Same thing with lab work, looking for inflammatory markers, looking for autoimmune markers, things like that.
Okay. Yeah.
Also, another big thing you'll see is nutrient deficiencies because of the digestive issues that go along with it, like SIBO and things like that.
Yeah. Oh, we're going to talk about SIBO. Okay. Well, one person did have a question about diagnosis. She was just saying that the client was diagnosed through sonogram that she had an endometrioma on her ovary, and I believe that's diagnosable via
Yeah.
sonogram if it's on the ovary.
Right. Well, so here's the thing about imaging.
Yeah.
If they find something on the imaging, then it's a positive. If
Right.
they don't find something on the imaging, it's not a negative. So that's
Right.
how it works. So yes, you can diagnose it, but you can't rule it out by imaging.
Yeah. Okay. That makes sense. Okay. Awesome. All right. So we have like a million more questions here. So diagnosis, we talked about that. We talked about the supporting ways of diagnosing, in addition to surgery. So the age, because you mentioned middle schoolers, you mentioned obviously younger girls. I feel like there's a misconception about diagnosis at a certain age just because it takes so long to diagnose. And for whatever reason, this is just, the pain women and menstruators are experiencing is constantly dismissed for years on end. So can we talk about diagnosing at a younger age? Because I feel like, if you're talking about the fact that this is, embedded in, when we're in utero, then clearly at your very first period, you could have an extremely painful period and be diagnosed with endometriosis, essentially, right?
Absolutely. So, so in a sense, the disease gets like activated at puberty. There is a hormonal component sometimes. So activated by inflammation hormones, there's a lot of chicken and egg there. And it's interesting because some of the data that came out in 2018 showed that we thought this was an estrogen driven disease, but actually some of the data that came out more recently shows that the lesions, some of them have estrogen receptors upregulated, some have progesterone receptors upregulated, some have both, some have neither. And all those different kinds of lesions could be in the same person. Right. So I don't really aim for sort of like really lowering estrogen anymore because of brain, heart, bone issues, but just kind of, just sort of optimizing hormones the best that we can for normal, healthy life, other things in life.
Right. Are there hormonal imbalances typically? That's something I was thinking about too, is that, just in looking at test results that I see come in through clients and whatnot, I've seen a bit of both. Like sometimes sex hormones are totally fine and other times they're all over the place. There's a low progesterone, high estrogen situation. Is that pretty typical as well? Like, is there a pretty clear pattern, or is it all over the place for the most part?
Well, it can be sort of any of the above. And it's not that estrogen dominance is causing this. Sometimes it may be driving it if your lesions are upregulated with estrogen receptors and lack progesterone receptors, which can be the case in a percentage of people, not always the case. So even if the hormones are perfect, the lesions themselves produce their own hormones and their own inflammation. So there's only so much we can control outside of the lesions actually driving their own survival, right? But in some women, it does help to suppress estrogen. The data, the absolute numbers is kind of, I like to say, generally 30% of the women, 30% of the time, if you look at sort of a combination of the studies. So it can be significantly helpful for quality of life to be on birth control in the short term, sometimes post-op. There are some times when that can be of benefit, but we have to take it in context. It's not like the solution to the problem. It's sort of calming symptoms in the short term for a certain percentage of people who do have lesions that respond to estrogen suppression. And the only way to figure that out is to try it and see if it works, and under sort of guarded circumstances, and being monitored, because there's always a double-edged sword, right? Because putting every 14-year-old with pelvic pain on birth control is also going to cause problems, because it increases the risk for vulvodynia, vulvar pain, which often co-presents with endometriosis, and increases the risk of depression and suicide up to 3 times, especially in adolescents. So while this is a tool, it has to be, used very diligently. And there are more aggressive forms of hormone suppression like Lupron and Orlessa that, again, even more aggressively have to be taken into consideration, because the side effect profile can be really problematic. So I know we kind of went on a tangent. I don't actually remember what the question is.
No, that's okay. It's fine. No, that's helpful too, because it's all about like the estrogen profile or the progesterone profile, and like what sex hormones look like typically. But I feel like you answered it.
Right. So they can be different presentations if you're looking at something like a Dutch test. My aim is not to suppress any of the hormones, but to optimize them just as we would anyone. But that's not essentially treating the disease in any way, or maybe even influencing. I'm just aiming to like help the rest of their health, like optimize brain health, optimize heart health, optimize bone health.
Exactly. Agreed. I know. And that's actually something I really want to talk about. So let's see. Oh, somebody asked about the age. She said, is there any correlation between getting your period at an early age and getting endo, and having endo being present?
Not that I'm aware of, but the symptoms usually start in pre-puberty. Now, the symptom picture is widely variable as well. You can actually have silent endo and, 1, never know about it. 2, know about it only when you try to get pregnant and struggle with infertility. Or you can have quote unquote stage 1 endo. The staging is not at all related to the symptoms. So you could have stage 1, stage 2 endo and have really severe pelvic pain that literally takes you out of your life for weeks at a time. Painful sex, vasovagal, depression, anxiety, fatigue, insomnia. You can have really severe symptoms and infertility without having severe disease. So the disease staging doesn't correlate with the symptoms, and the symptoms are wide ranging. And for some people, there's a pretty clear timeline, like between 8 and 12, start presenting with digestive issues, bloating and constipation are most common, but sometimes diarrhea, food aversions, food sensitivities, things like that, which is tricky because it can co-present with eating disorder and all of that stuff that can happen from 8 to 12. So we have to be really mindful about how restrictive the food plans are. And then when the periods start, painful periods, pain in between periods, pain with ovulation, still digestive issues, because usually what happens is people are sent down a GI tract and they don't really find anything. Maybe they find SIBO if they're with a more progressive GI physician, but then can be years of trying to figure that out, and then don't really figure out what's going on. It takes about 6 to 12 years to diagnose. And one other myth is that at menopause endo goes away. That is not true. If it was not treated, it's not like it just goes away. The other big myth is get pregnant and it'll just go away. Neither of those things are true. Pregnancy is not a cure for endo. Menopause is not a cure for endo. So you don't have to ever deal with it, but hysterectomy is not a cure for endo, because by definition, endo is outside of the uterus. Now, a similar disease to endometriosis is adenomyosis, which is lesions in the muscle of the uterus. That the treatment for adenomyosis is hysterectomy, but that's sort of a last resort situation, because again, there are other situations going on. And some people have both adenomyosis and endometriosis, but generally speaking, absolutely not. Hysterectomy is not a treatment for endometriosis.
Okay. Yes. Thank you. This is so good. People are asking about treatments and about the pill, and I want to talk about that. So obviously there are lots of treatment options that are presented. Well, not lots, actually, that's not true. As far as I'm concerned, I feel like there are lots of things that we can do working with someone like you or someone like me or someone else who does a nutritional and lifestyle based, takes the nutritional and lifestyle based focus. But, I would love to know what you do with your patients, because I feel like that will give people some clarity on what other options they have, because obviously in most cases people are presented with the pill, and that's not a great solution, as you just described.
Absolutely. So that's not the only option. And by the way, the pill does not cure endometriosis. The only thing that removes the endometriosis is surgery. Lifestyle strategies don't, herbal medicine doesn't, naturopathic medicine, clinical nutrition, functional medicine. All of this is symptom management and slowing of growth, slowing of proliferation, improving the autoimmune picture, improving symptoms, improving fertility. Actually, for most of my clients who have fertility goals, I think it's more especially important to have a surgical consult. The earlier you do it, the better. There's a bit of a window, like there are obviously risks to having 14-year-old surgery that could be improved if you wait a few years, to late teens, 20s. You have to think about this in context of your life, because if it's going to take 4 to 6 weeks to recover, even just basic surgical recovery. So when do you fit that into your life and your school schedule and your college applications and all of that kind of stuff? And then it's not just a bounce back, like it can take 6 to 24 months to fully, optimize your health. So in our program, our goal is to prepare for and recover from surgery. Now, there are some people who choose not to have surgery or are not good surgical candidates for many reasons, and that is okay. Endometriosis is not cancer, so it's not deadly. However, it does increase the risk for ovarian cancer about twofold, maybe even more. So that's serious, because ovarian cancer is often not diagnosed till too late, and it has a high rate of mortality. So being kind of on the lookout for that if you have endometriosis is important. But, whether or not a surgical decision is made between you and your surgeon, we can still do all of the things we can do to improve symptoms. And fertility is a little controversial. We don't really know if we can improve fertility this way. We have no data. Right. But what we do is we work with people in roughly a 4 to 5 month program, whether or not they have surgery. Ideally, they have surgery about 3 to 6 months after preparing their bodies. Yeah. That would be optimal, and I'm working on that. More and more of the surgeons are on board. So ask your surgeon, say, can I work with a nutritionist and health coaching team and physical therapist who specializes in endometriosis prior to this surgery so I can get my body ready? Then post-op, we figure out what you're going to have in your freezer to eat. We figure out who's going to be taking care of you. We figure out what your post-op mobility plan is going to be, because there is a lot we can do. We optimize 4 physical systems. Nervous system, stress plays a huge role. And we do that by measuring heart rate variability. It's a measure of parasympathetic and sympathetic nervous system. The more robust your stress resilience is, and sometimes we look at cortisol levels, but basically optimizing stress resilience, good quality sleep. We measure and track sleep. We're looking at ways to do that more and more passively so that we can collect good data and make sure it's effective. But it seems to be working well. In the last year, we've implemented that. So we focus on optimizing HRV, optimizing deep sleep between 10 p.m. and 2 a.m. And then we focus on anti-inflammatory nutrition, which there's a range of ways that will work with people. Some are more kind of autoimmune paleo keto, depending on some of their genetics. Some people do well with a more vegan plan in the short term. Some people can tolerate grains and beans. Some people can't. Most people have to go off sugar. We also have to look at things like, do they have oxalate sensitivities, histamine sensitivities, candida overgrowth, chronic UTIs, chronic vaginitis, chronic BV, things like that, vulvodynia. So we look at all of that in context and work on optimizing the nervous system, the digestive system, which again, we have to deal with constipation and quote unquote endo belly, which is a bloating that's really common in endometriosis, because if the lesions are growing on the small intestine, the motility is messed up. And so a combination of visceral physical therapy, good motility supplemental support, good digestive enzyme and stomach acid support, and then treatment for SIBO in a wide vision approach, not just throwing Xifaxan at it, which it could be part of the solution, but it's not the solution. We have to figure out why someone has SIBO and then address that. Address motility, address toileting, address, people need squatty potties sometimes and pelvic floor down training and all that kind of stuff. What's the gut microbiome? So we address nervous system, digestive system. We refer all of our patients to pelvic physical therapy if they're not already seeing one. Most of the time they are. That's essential for pain management, scar management, post-op symptom management, nervous system down training, pain science education, and then immune health, which is intricately related with digestive health. Yeah. And I wouldn't say there's necessarily a higher risk for people getting COVID, but in this COVID environment, several of our patients have also gotten COVID in the midst of it. So we want to make sure they're as resilient as possible because, it's an active young population. They're out in the community. So we want to optimize immune resilience, but be mindful of autoimmunity and excessive inflammation and the discoordination that happens with excessive inflammation. So those four systems, nervous system, digestive system, immune system, and musculoskeletal system, where the physical therapists are involved, there are a lot of things we can do that over a slow trial and error, personalized approach with making day-to-day changes, assessing how the body responds to those changes, getting the body prepared as possible, then the pre-op and post-op course are just so much smoother and you get to that more complete level of healing.
Okay, so it's obviously not just about the pill, people. There's so much more.
It's not.
Yeah, there's so much more. So hopefully that answered a lot of questions because someone asked about scar tissue and other people were asking about the pill and whatnot. That was amazing. And that's exactly what I really wanted to communicate to everyone because I think people are completely unaware of all of the steps that should be taken and can be taken to work on not only your health pre-operation, but then post-operation, because the goal here is for it to not grow back. And so I'm curious about that, actually. So I feel like the goal is for it to not grow back. So if that's the case, you're going to be continuing those changes basically forevermore.
Correct. Now, yes. Now, sometimes endo does grow back. These surgeons are human. They're not perfect machines. Sometimes, people become more resilient. So being on this kind of plan for the rest of your life is the truth, but it can get more flexible as resilience builds in the system. Yeah. You take the endo lesions out, you eat really well for 6 to 12 months, then you go to a birthday party and have some chocolate cake, fine. Like you're not going to suddenly have an endo lesion grow back, right?
Right.
They can be small where they're missed even by the best surgeons. So maybe they didn't grow back, but they were somewhere else and, they didn't see them that first time. But yes, the goal is to optimize inflammation forever, optimize immune health forever. That also likely will expand the fertility window because the immune system becomes healthier, the gut microbiome, the vulvovaginal microbiome, the urogenital microbiome, and you don't have the autoimmune causes of infertility that are often related to this disease. So the data has shown improvement in that up to about a year. We did some research on vulvodynia that showed improvement in that up to about 21 or 22 months. You know, we haven't studied people for decades, but, you know, being able to improve that window of fertility from an immune standpoint is really important for a lot of people's fertility goals. And so that's really important. So yes, this is a lifetime lifestyle, building resilience, a bit of trial and error, lots of support over, you know, a total of roughly 6 to 24 months, which can sound like a long time, but 74% of women who have endometriosis who don't have the time and resources and to invest in that kind of healing, that sort of comprehensive healing, feel that like their lives are derailed. Because if you can't show up for work several days a month, it's very difficult to go to grad school, to go to high school, to go to college, to go to work. Even in our work from home environment, which is obviously to some cases can be better, you still can't be brain foggy and you still can't be exhausted and insomnia. Blah, blah, blah. So there's this derailing of life. So, you know, right now the problem is that this is expensive treatment, quite frankly. We haven't been able to find a way to leverage it. We've tried many different things. It's so personalized that we have to have skilled people working with you for a period of time. Same thing with the surgery. It's not well reimbursed. Only, you know, a small number of really skilled people do this globally. And there are some options of partial use of insurance and things like that. But I think one of the things that we need to make our next step argument for is funding through government agencies, through insurance companies. You know, this is really important. Affects 1 in 10 women. So some kind of public funding of really skilled people to do this work. There's no shortcut. You know, I've looked for 10 years for the shortcut. I've looked for the quick way we could do this. You know, yes, hormonal birth control is much cheaper. You can mask the pain. Other drugs can sometimes improve the symptoms enough so people can function. But none of those things are really addressing the root cause of the problem. Yeah. And so I don't know how to fix this, but I think if, you know, this is something that we need to try to advocate for more funding for, to help more people be able to access good quality care. Right now it's expensive, and the people who really do it well are few and far between.
Yeah, I could not agree with you more. And I feel like it's so unfortunate because I obviously come from a country outside of the US, and I know a lot of women who are dealing with this condition in places that there are no surgeons, there are no doctors who even understand this. If they have the means, they travel to the US or the UK or something like that. But that, I mean, that it presents a whole other can of worms. I mean, it's impossible for millions of people to access any kind of quality care.
Now, I would say it is unfortunate. I did try to write it down. So you did. It is. I did write it down. We actually just got the physical copies of this book earlier this week. Oh, so that's exciting. So I did try to write it down. So there, depending on how complicated your circumstance is, this book really does kind of map out exactly what we do in our practice. People get stuck sometimes because I always relate it to this. You know, literally you can go on YouTube or Amazon and learn how to renovate your bathroom, right?
Right, yes.
I would never do it because I would get stuck at some point with water like pouring out of my wall.
No doubt.
Right? So this does map it out, but it is true that it's challenging to really implement every bit of this because it can be a little bit overwhelming. But I really tried to do that. And the other thing you can do is take this to your providers and your team and really try to help them help you think through some